Alright guys, so today we're going to be starting with a new chapter in the first aid for USMLE Step 2 CK, which is the renal genitourinary chapter. And before this, we have read the endocrinology section. Now, this is a very casual, very informal series about reading together the first aid Step 2 CK chapters. And in my personal recommendation, I recommend that you see these lectures as a source of building your foundation instead of using this in your main preparation. So you watch these lectures, you study the first aid for step 2 CK, and you build a foundation, you get an idea of how different sections are distributed and how everything is asked and how much content should you focus on. So that is the main purpose of these lectures. And today we're going to be starting with the renal genitourinary lecture, the first lecture, and going to continue it, and we'll see how much we can finish this in today's video. So let's get going. Starting off with the electrolyte disorders. The first one is hypernatremia. So serum sodium greater than 145 milliequivalents per liter is usually known as hypernatremia. So the normal value is 135 to 145, and when you go above 145, then you start to call the condition as hypernatremia. So all of the terminology is in relation to the plasma levels. So all of the electrolyte disorders and hyponatremia, and all of the electrolyte disorders, so on, are named as or studied as their relative concentration in the plasma, not in any other body container, not intracellular, not intravascular, plasma only, right? So you have to keep this in mind that when we're saying that there is more sodium, we actually mean that the sodium is more in the plasma, right? So hyponatremia is usually caused by free water loss rather than sodium gain. So that is the main mechanism of hyponatremia. Because if you're just eating more sodium, the sodium will attract water, and when the sodium attracts water, it doesn't usually cause isolated hyponatremia because sodium and water both will increase. So if I could show you that if there is just increase in sodium, this will lead to the increase in water reabsorption, right? So water follows sodium, so you won't really get hypernatremia. But if in its place there is a loss of water, let's say the water is moving out, right? Then you will get increased sodium in the body, which will cause isolated hypernatremia. So this is what they're trying to say is that this is usually caused by loss in free water rather than sodium gain, and this is usually caused in diabetes insipidus. So we've already looked at the endocrinology chapter. We have videos on it on our channel. You can view that. But this is essentially what they're saying, right? So the key fact is that certain patients, infants, intubated patients, and immobilized patients, and those with altered mental status, may not drink enough free water to replace insensible losses. So this can worsen the hyponatremia. So these are some subtle conditions such as infants, intubated patients, and immobilized patients, and those with altered mental status. So you need to keep in mind these subtle situations. They can come in your exam as a clinical presentation, so you have to keep in mind. So history physical examination presents with thirst, which is caused by hypertonicity, of course, and neurological symptoms, including altered mental status, weakness, focal neurologic deficits, and seizures. So these are some of the neurological symptoms that accompany sodium disorders. You can also find some in hyponatremia as well, but these you have to keep in mind for hyponatremia, right? So let me get this out of the way. So for diagnosis, they're saying there's a diagnostic algorithm, and in figure 2.16, we'll view that in a bit. But the diagnosis is based on urine osmolarity and urine sodium. That is something important that you have to keep in mind. I'll explain it a bit further, uh, explain it later on a bit further, but it is usually based on the urine osmolarity and urine sodium. So let's see the mnemonic here, which is hyponatremia causes the 6 Ds: diuresis, dehydration, diabetes insipidus, DOX, iatrogenic, diarrhea, and disease. So these are the causes of hyponatremia. So this is easier for you to remember as the 6 Ds, right? And this is the diagnostic algorithm for hyponatremia. It's figure 2.16. So what they're saying is basically what hyponatremia is first looked at. We look at the urine osmolarity. So if the urine osmolarity is low, then there are different causes, and if the urine osmolarity is high, then there are different causes. So looking at the low urine osmolality causes, what happens is that if the urine osmolality is low, which is lesser than 300 osmoles per kg, there is a rise in the urine osmolality with decompression following water restriction. So there is the more water is reabsorbed. So there is central DI, FEC. And then if there is no rise in the urine osmolality with decompression following water restriction, then there is nephrogenic DI. So what basically it means that if urine osmolality is low, then there is more water in the urine as well. It's not just it's sodium is losing. There is more water in the urine, so the urine is dilute, right? Dilute urine we could find in only two causes, and those are either it is diabetes insipidus, or either you can find it in psychogenic polydipsia. But this cannot be psychogenic polydipsia because psychogenic polydipsia is euvolemic condition. It is not a hyponatremic condition, right? So if the patient is already in hyponatremia and its urine osmolarity is low, we look at diabetes insipidus. And then there are two causes of diabetes insipidus. So then what we do is we do water restriction, which is the first step in the diagnosis of the type of diabetes insipidus as well. So these both of these algorithms overlap. If you want to diagnose diabetes insipidus further, the first step is water restriction. Now, what you find in water restriction then further narrows down the diagnosis. So if the patient undergoes water restriction and they find that the urine osmolality is rising, then it is central DI. But if the patient undergoes water restriction and they don't find any rise in the urine osmolality, then it is nephrogenic DI. And the difference is that in central DI you have a deficiency of ADH, and in nephrogenic DI you sort of the kidney is desensitized uh, with respect to ADH, so it's not sensing ADH, so it's not working. The ADH is not able to exert its effect. On the other hand, if you look at the urine osmolality and it is high, which is indicating that sodium is sodium is lost in urine, or there is less water in the urine. That is a better way of saying it. That there is less water in the urine. That is why urine osmolality is high. So what could be the causes? The causes should be that if there is less water in the urine, which means there is less water in the body. So what is happening is that there are external losses of water, such as vomiting, diarrhea, nasogastric tube, insensible losses. So water is losing, and you're getting hyponatremia, as we said before, that free lot of water is losing. In this case, in this scenario, water loss is through uh, urine, right? In this scenario, there is also water loss, but the water loss is in the body. That is why the body is having less water, and that is why the urine is also having less water. Now, how did the body lose the water? The body lost the water from vomiting, diarrhea, nasogastric tube, and insensible losses. But there is another cause in which somehow, if you are able to gain a lot of sodium ion, so that is also a cause for hyponatremia. If somehow you're able to gain a lot of sodium ion, for example, hypertonic saline infusion, which maybe it was supposed to be for like 10 minutes, and then the doctor did not pay attention. The doctor did not pay attention, as we said, that docs are also a cause of hyponatremia. So maybe the doctor did not, or the nurse did not pay attention, and the hypertonic saline solution, which was supposed to be there for 10 minutes only, has now lasted for more than 10 minutes. And so the body has gained a lot of sodium ion. So what has happened is that although the body has not lost water, it has gained a lot of sodium. Now, this is a rare occurrence. Main occurrence is through the loss of water, but this is a rare occurrence. So what happens is that, of course, if the body is gaining a lot of iron and is being hyperosmolar, then the body would try to save water. So again, there is less water in the urine in this case also. So the overarching theme is that there is water loss, either through urine or either through the body, right? There could be sodium gain also, but again, this is a rare cause, and this is the mechanism of how it can be done. This the infusion of hypertonic saline. So the diagnosis of nephrogenic central diabetes insipidus and nephrogenic diabetes insipidus also established by the use of DDIP replacement test, which is the desmopressin test that you can also do. So what happens is that intermediate values, often caused by osmotic diuresis, though can occasionally be seen in diabetes insipidus. Urine sodium measurement can also be helpful in distinguish extra renal losses. Urine sodium is less than 25 from sodium gain, which is more than 100 milliequivalents. Also, in this case, our body has a lot of sodium, so it is trying to excrete the sodium in the urine, and that is why more sodium is also present in the urine, which raises the urine osmolarity. So I hope this is clear now. This is how we move from how we diagnose hyponatremia, different causes of hyponatremia. So the treatment now is to determine the volume status, right? If the patient is hypovolemic with unstable vital signs, you can use 0.9% sodium, and this is usually the first step in your exams when they're asking a hyponatremia or hyponatremia question or any electrolyte disorder question. This is usually the correct step, or if I could say, this is usually the correct step involving sodium disorders, the 0.9% NaCl. If there is a normal volume status and the patient is asymptomatic, then you can treat with 0.45 normal saline, because 0.45 is less uh, has less osmolarity and is more dilute. It has more water. So that's the concept behind it. So the concept behind it really is that the dextrose water and 0.45 normal saline are hyponatremic fluids, hypotonic fluids. That is a better word, right? They are hypotonic. So if I could write it, they are hypotonic. They have more water. So if the patient is hyponatremic, obviously you give them dilute fluids or fluids that are hypotonic, that will sort of fix the iron problem, the electrolyte problem. But before that, you need to determine the volume status. That's very important. So if the patient is hypovolemic, which the patient usually is, then you have to give the 0.9% normal saline before correcting any other deficit. So you use the 0.9% normal saline until the patient is euvolemic, even with stable vital signs. So you need to fix the volume status first. That is important. And then you determine the free water deficit. There's a formula for this, which is the water deficit is equal to the total body water multiplied by the serum sodium divided by 140 minus 1. So this is a formula for you to remember. Although personally, this was not tested at my time, and this is not something that you should memorize. But basically, if you just focus on the if you just focus on the variables, so water deficit is almost always equal to the total body water and the serum sodium. So if you increase the direct relation of what if you increase total body water or serum sodium, you increase the water deficit. That is what I remembered. But if you can remember the formula, all well and good. It's not really important. A fact here is that total body water is around 60% of lean body weight, right? And you replace when you figure out the free water deficit, then you replace it with hypotonic fluids such as the dextrose 5 water or 0.545% normal saline. So volume status first, then the water deficit. Now there is something that you must be careful is that there is a rate of replacement. So, and this is a very important fact. So correction of chronic hyponatremia, which is more than 45 hours, should be accomplished gradually, right? Or 48 to 72 hours, which is less than zero point 0.5 milliequivalents per liter per hour to prevent neurological damage secondary to cerebral edema. And if the patient is euvolemic or hypervolemic, hyponatremia, they are treated with combination of diuretics and D5 water to remove extra sodium. So this is not really important. This is a very important fact that you should memorize. That if the patient is acutely hyponatremic, then you can treat the patient acutely or rapidly, right? If the patient is chronically hyponatremic, which they've said more than 45 hours, 48 hours, then you should do the correction gradually. And this is the rate that they have mentioned, less than zero point 0.5 milliequivalents. Or else you can go towards cerebral edema. So you must have remembered there was a mnemonic in step one, which says that, which was like from high to low, your brain would blow, and from low to high, the pawns would die, right? So I think I should write this because this might be helpful for you. So from high to low, your brain will blow, and from low to high, your pawns will die. This is the mnemonic. So obviously you can understand from high to low means from hypernatremia to hyponatremia basically means from increased sodium to decreased sodium. The complication that you need to be worried about is cerebral edema, which is signaled by the brain will blow. This means edema. And from low to high, which means from hyponatremia to the increased sodium levels, your pons will die, which means osmotic demyelination syndrome. So you need to keep this in mind, the osmotic demyelination syndrome, which is characterized by locked-in syndrome. Right? If you could remember, the patient becomes quadriplegic, and only the vertical movement of the eye is preserved. So this mnemonic would help you. So this complication you need to be careful. And one other fact that I must repeat: if the patient is acutely hyponatremic, you can do rapid correction. All right, not too rapid, but you can do rapid correction. If the patient is chronically hyponatremic, you have to do slow correction. Right, that's very important. Very important for you to understand this. It's not important for you to memorize the rate, but this fact is alone very important. And then we move on to hyponatremia. So obviously, if 135 to 145 is the range, normal range, then serum sodium less than 135 would be counted as hyponatremia. And hyponatremia is most commonly caused by increased ADH. However, there are some ADH independent etiologies like primary polydipsia, starvation, and the presence of a non-sodium effective osmole in the electrocellular extracellular fluid. Why is it mostly caused by increased ADH? Because increased ADH causes more water reabsorption. Increased water reabsorption would obviously reduce the presence of sodium ion in the plasma and would reduce its value in the blood. So it can cause hyponatremia. But there are some ADH independent etiologies, like primary polydipsia can sometimes cause hyponatremia. So you need to keep this in mind. Earlier I mentioned that it is euvolemic, but you need to keep it in mind that euvolemia is a volume status, but as an iron problem, it can cause hyponatremia. Right? Starvation can also do that because solutes will be deficient, and also the presence of a non-sodium effective osmole. Some osmole that is non-sodium is not sodium, but is equally as effective in osmolarity in extracellular fluid. On history, physical examination may be the patient may be asymptomatic or may present with confusion, lethargy, muscle cramps, and nausea, and can progress to seizures, coma, or brainstem herniation. The diagnosis is reached by the best initial test is measurement of serum osmolarity as the first step in evaluation. And if the serum osmolarity is higher than the calculated serum osmolarity, which is usually by this formula right over here, by more than 10 to 15 osmoles, then this indicates an exogenous osmole, a non-sodium osmole, diluting the serum sodium. So if you're given a question and then the question is the question gives you serum osmolarity, but you use this formula and you put in the values, all of these values must be given in the question. They would be given in the question. So you put this formula in and you calculate it. And if it is more than 10 to 15 osmoles, then this indicates that you have an exogenous osmole. So this would confirm one etiology at this step right now, right here. So this would confirm this etiology, right? Again, I will say that I personally did not memorize this formula because you don't really need it to solve many questions. But if you have a perfect personality, you can go ahead and memorize this. This would help you in these kind of questions. Not that this is completely useless, but I sort of got along without memorizing it, so it didn't really affect me. Correct sodium. Let me remove this. So correct sodium in hyperglycemia. Sodium decreases by 1.6 milliequivalents for every 100 milligram per dl elevation in glucose. So you need to memorize that, and you need to apply this knowledge in questions also. It's not just for memorization, but the reason why you're memorizing this is because it will help you tackle the questions easier. And hypotonic hyponatremia is the most common and is further Hypertonic hyponatremia is the most common, is further categorized by volume status, and it is summarized in the figure 2.162, which is this. So we have to discuss this. Before this, there is a key fact that consider using hypertonic saline only if a patient has seizures caused by a hyponatremia and when serum sodium is less than 120, because in most cases normal saline is the best fluid. So as I've said earlier, that is your go-to normal saline is your go-to answer for any question regarding sodium disorders, right? This would be your first choice. But then if the question is a bit difficult and it's going deeper, then either you need to check if the patient, if levels are less than 120, sodium levels are less than 120, then you go for hypertonic fluids or sodium tablets or hypertonic fluids. Or if the patient is having seizures, which is a dangerous complication. The patient is having seizures or the level is less than 120 milliequivalents of sodium, then you can only use hypertonic fluids or sodium tablets. But if both of these conditions are not met and the patient is still uh, hypotonic, the patient is still hypotonic, but he's not having seizures, or if the value is not less than 120, then you're not supposed to go towards hypertonic replacement. Then you can simply give normal saline and it will work. So that's the difference that you must keep in mind. This is very important as far as questions are concerned. They usually test these facts that you must know. Now we discuss this diagram of hyponatremia. So basically, first step is to see the serum osmolality, right? You either there's less than 280 milliequivalents, more than 295, or 280 to 295, right? This would be hypotonic, this would be hypertonic, and this would be isotonic. So if the patient is hyponatremic and he's isotonic, then you just need to measure lipids and proteins, because hyperlipidemia or hyperproteinemia can usually induce negative charges and they can basically induce hyponatremia. So as we said that the patient would have any osmole other than sodium, non-sodium osmole causing hyponatremia. So these are the non-sodium osmoles, right? So you need to check this, but only this when the serum osmolality is isotonic. That's what you need to keep in mind. But if the osmolality, on the other hand, is hypertonic, then you need to measure. Then you need to measure the if it's hypertonic, then you need to measure the glucose level, such as the hyperglycemic condition, or if the patient is has undergone any mannitol treatment or any contrast agents. So that would clarify the hypertonic etiology. If the serum osmolality is hypertonic, then you clinically assess the extracellular fluid volume. Now you go towards the fluid volume, right, which might be low, normal, elevated. So if it's elevated, then it is hypervolemic hypertonic. If it's normal, it's isovolemic hypertonic, or if it's low, then it's hypovolemic hypertonic, right? And then you move on further. So if it's hypovolemic, what you do is you measure the fractional excretion of sodium. So if it's low or if it's high, then you would know basically what is the etiology. If it's low, it means that the water loss has happened before, like extra renally. The body is not trying to lose water through urine. It has already lost water from other causes, such as these GI losses and all of these. That is why the fractional excretion of sodium is low, because they want to preserve water. But if the fractional excretion of sodium is high, which means the body wants to lose water through urine. So what is happening? The causes that can induce water loss through urine would be diuretics, urinary obstruction, adrenal insufficiency, and bicarbonaturia, which is RTAs or metabolic alkalosis, right? So this is the concept behind it. If the patient is hypovolemic, so he might as well be losing water somehow, then you need to check if he's losing water in the urine. And the best way to do that is to check the fractional excretion of sodium. When the patient is isovolemic hypotonic, then you have to check the urine osmolality, right? You need to check the urine osmolality, that if the patient is losing sodium, now the water status, the volume status is fine. Now we just need to find out how the patient is losing the hypotonicity. How is the patient losing sodium, basically? So then we will check the urine osmolality. If the patient is losing sodium in urine, or if the patient is losing sodium uh, with water, right? So if the patient is exclusively losing urine in the using sodium, losing sodium in the urine, if exclusively the patient is losing sodium, then the causes can be SIADH, hypothyroidism, glucocorticoid deficiency. If the patient is losing sodium but with water, then the cause is high primary polydipsia and beer potomania, which means too much beer consumption. And then we go towards the elevated part, in which if the patient has higher volume, right? So then you again measure the fractional excretion of sodium, because now we are again talking about volume. So in hypervolemia and in hypovolemia, we need to find out where the water is coming in or going out. So in hypovolemia, obviously, we need to find out how is the water going out. In hypervolemia, we also need to find out how is the water coming in, or if it's not going out at all. So in both of these cases, we measure the fractional excretion of sodium. So if the fractional excretion of sodium is low in this case, in hypervolemia, it means that the patient is basically cirrhotic, or he's undergoing congestive heart failure or nephrotic syndrome, which means there is just too much water in the body, right? It's too much water in the body. If the patient has a fractional excretion of sodium greater than 2%, which means there's either he's not really losing water, the kidneys are not working properly, the body is not pushing out water, right? In this case, there is just too much water present in the body. But in this case, the body is not excreting water. And that could only be two cases if the kidney is not working properly, right? Either is some kidney problem, which is acute kidney injury, chronic renal failure. Only then the body might not be able to excrete enough water. So this is the algorithm for hyponatremia. This might seem a bit confusing at first, but once you go over it 2 to 3 times, and once you go over UWorld for this, then this won't be a problem for you, because it is quite easy. Electrolyte abnormalities are very easy to identify in the test, and they're very easy to treat as well. So continuing on, they have given us a MRI image of osmotic demyelination syndrome, which is basically, as we've discussed, if you correct hyponatremia too rapidly, it can lead to a complication known as osmotic demyelination syndrome, which is the same as locked-in syndrome, in which the patient becomes quadriplegic, and he can only do vertical movement of the eyes. So only the vertical movement of the eyes is preserved. All other movements of the body are restricted. So that's what osmotic demyelination syndrome is. And you must remember the mnemonic that we discussed earlier, which was from high to low, your brain would blow, and from low to high, your pons will die. So you can see this area of uh, discoloration, which is a bit pale and inconfluent with the surrounding area. So the color over here should be same as the color over here, but it isn't, which means demyelination has occurred in this area. So that would give rise to the osmotic demyelination syndrome. Now the treatment is to first treat the underlying disorder, the conditions that are causing the hyponatremia. So conditions such as SIDH, hypothyroidism, primary polydipsia, cirrhosis, or the use of diuretics. Basically, all these conditions that you first used the algorithm to narrow down, you need to treat these first. So this would, in most cases, reverse the hyponatremia. But if it doesn't, then you have to treat the hyponatremia from hypervolemic and euvolemic changes with water restriction only. And sometimes you can use diuretics. But if the patient is hypovolemic, then you must first correct the volume status through normal saline, as we've discussed quite a lot of times. But if the patient is severely hyponatremic, which means that the sodium is less than 120, then you must consider using hypertonic saline solution or salt tablets. So this is an important fact that we I discussed with you extensively, and you must remember this: that when should you go for hypertonic solutions, and when should you consider using salt tablets, and when should you consider using normal saline only, and when should you consider for observation or water restriction only. So you have to remember this. This is a very important paragraph. Now, to correct chronic hyponatremia, which is signified by greater than 72 hours of duration, you do it slowly, which means 8 to 10, less than 8 to 10 milliequivalents per liter per day to prevent osmotic demyelination syndrome. As I've said earlier, the rule applies to uh, sodium also, that if the patient is acutely hyponatremic or hypernatremic, then you can rapidly correct the sodium levels. But if the patient has that abnormality or uh, dysregulation chronically, then you must correct that dysregulation or abnormality slowly, and you cannot correct it rapidly. So this is a difference that you must remember. All right. So this is a mnemonic for the treatment of hyperkalemia, which we can see after a while after discussing hyperkalemia first. So hyperkalemia is potassium greater than 5. The normal value is from 3.5 to 5. So potassium greater than 5 is considered hyperkalemia. The etiologies are as follows. So why does the hyperkalemia occur? Spurious, which means hemolysis of blood samples, fist clenching during blood draws, delays in sample analysis, extreme leukocytosis or thrombocytosis. So in all of these, in all of these, uh, basically there's a breakdown of cells, and potassium is concentrated inside the cell. So anything that destroys the cell is releasing potassium into the blood. So potassium is not concentrated outside; it is intercellular ion. It is concentrated intracellularly. But the problem is that when the cell is broken down, potassium is in the blood, and that can give rise to hyperkalemia if the problem is in big magnitude. Second etiology is decreased excretion. So, renal insufficiency, drugs such as diuretics, such as spironolactone, trimethoprim, amiloride, ACE inhibitors, trimethoprim, NSAIDs, beta blockers, hypoaldosteronism, type 4 RTAs, calcineurin inhibitors, all of these can decrease the excretion of potassium, leading to hyperkalemia. Cellular shifts, so again, cell lysis, tissue injury, uh, mostly rhabdomyolysis. This is important. This is very important for you to remember. Tumor lysis syndrome, insulin deficiency, acidosis, drugs such as succinylcholine digitalis, arginine beta blockers. Beta blockers usually block the sodium potassium ATPase, so that's why potassium remains elevated outside the cell, because that pump is not working to push potassium back inside. Hyperosmolarity exercise, resorption of blood, hematomas, and GI bleeding can also give rise to hyperkalemia. And lastly, if there is an increased intake of food, which is mostly fruits and potatoes, they are rich in potassium. So if there is an increased intake of these, they can give rise to hyperkalemia as well. And iatrogenically, if there is an infusion of potassium or if there is an unchecked intake of potassium in the hospital setting, then it would be known as an iatrogenic injury. Right. So key fact: patients with metabolic alkalosis, hypokalemia, and a normal BP probably have one of the following conditions: vomiting, diuretic abuse, Bartter syndrome, Gittleman syndrome. So I think this is a fact for afterwards, not now when we'll study hypokalemia. But you must remember that patients with metabolic alkalosis and hypokalemia can have these conditions because these conditions can cause hypokalemia. But we'll discuss them in a bit. So, on history and physical examination, the patient may be asymptomatic or may present with nausea, vomiting, intestinal colic, areflexia, weakness, flaccid paralysis, arrhythmias, and paresthesia. So, all of these symptoms you have to remember are important. Blood intestinal colic, areflexia, weakness, flaccid paralysis, arrhythmias, and paresthesias. All of these are important. For diagnosis, you confirm hyperkalemia with a repeat blood draw for suspected spurious results. In the setting of extreme leukocytosis, thrombocytosis, check plasma potassium levels. So you do a repeat blood draw for any spurious etiology if you are suspecting that, of course. Other workup is you need to do an ECG because, as you said, it can cause arrhythmias. So you need to do ECGs to rule out if there is any cardiac manifestation that is occurring due to hyperkalemia. If there are ECG changes, what should they be? They would be tall peaked T waves, a wide QRS, PR prolongation, and loss of P wave. So as you can see right here, there would be a peaked T wave, QRS prolongation, PR prolongation, and there would be a loss of P waves, as you can see. So all of this is important. This is absolutely important for you to remember the ECG changes in hyperkalemia. These are very important. So now treatment. So before reading this, why don't we read the mnemonic study? So the treatment of hyperkalemia is C big K, which means calcium chloride or gluconate, intravenous, bicarbonate, beta 2 agonists, insulin plus glucose, and lastly K-axylate, which basically helps potassium to exit. K-axylate means potassium to exit out of the body. Right, so treatment is listed in the mnemonic, or it is summarized as the best initial treatment to always give calcium gluconate for cardiac cell membrane stabilization. If potassium greater than 6.5 or ECG changes. So the most important concern in hyperkalemia is the cardiac stabilization because if any ion can give rise to a change in ECG, which means that the heart is in problem, right? So you need to first look at the heart, the most emergent condition. So the best initial treatment is to give calcium gluconate for cardiac cell membrane stabilization for in cases of potassium greater than 6.5 and with ECG changes. So you can also give, after this, you can give insulin with glucose to avoid hypoglycemia. You can give beta agonists such as albuterol, which can power the sodium potassium ATPase to re-establish the correct concentration of potassium and sodium throughout the cell membrane. Or you can give bicarbonate to temporarily shift potassium into the cells. This is the most rapid way to shift potassium into the cells. So bicarbonate induces alkalosis, and alkalosis usually cause hypokalemia, right? What else you can do is to eliminate potassium from the diet, and medications which have potassium, such as penicillin has potassium, and IV fluids have potassium. To remove potassium from the body, you give Kayexalate, which I said it means for potassium to exit out of the body. The contraindications are ileus, bowel obstruction, ischemic gut, or pancreatic transplants, because they can cause bowel necrosis. That is the only contraindication to Kayexalate. Ileus, bowel obstruction, ischemic gut. And because of serious adverse effects, Kayexalate is falling out of favor. IV saline in hypovolemic settings and loop diuretics can enhance urinary excretion. So this is more preferred. This treatment is more preferred rather than using Kayexalate. But as far as the exam is concerned, they usually don't ask Kayexalate anymore. Dialysis is needed for patients with renal failure and hyperkalemia, refractory to above medical management. So this is the last option. Dialysis, of course, for to filter out potassium from the blood. Key fact: hypokalemia is usually caused by renal and or GI losses, with or without GI losses. So this would be we would study in the hypokalemia section. But I hope this is clear till now, because treatment of hyperkalemia is very important.